Hello, everyone. Good morning, good afternoon. Yeah, we just started the webinar. Let me see.
Okay. Good morning, good afternoon, everybody joining. We're just going to give it a few minutes for to allow people time to join the webinar. So just bear with us for 1 second, just to give everybody an opportunity. Fantastic. It's lovely to see all the messages. Okay, as we're 4 minutes over, I think we're going to begin and welcome everybody. My name is Rachel Halford and I'm the current president of the World Hepatitis Alliance, and I'm absolutely delighted to be with you here today in this webinar and to do it jointly with WHO, the WHPRO region. It's fantastic to have this opportunity. We have a few housekeeping messages first of all. The webinar that you're here today is recorded. There are some presentations and the presentations and the videos that you'll see today, you will be able to pick up later as it's been recorded. If you have any questions and answers, please put them in the Q&A box, or messages, just pop them into the chat box. I think everyone's familiar. You can see the diagrams on the screen. There is a live transcript in English, which will be available by clipping the captions. That's a new one on me. So you can see in the diagram, the CC captions. Okay, fantastic. Any queries at all or any questions, just put it in the chat box and we'll answer them for you if they're technical. Okay, so as I just said, my name's Rachel Halford and I'm delighted to be here with you today just to co-facilitate this session, which is an opportunity. So the World Hepatitis Alliance and WHO wanted to just hold on to this momentum that we have from World Hepatitis Day, and also follow on from the success of the World Hepatitis Summit, celebrate the messages, the take action, and all the incredible activities we've had since World Hepatitis Day, and just keep our agenda. Sorry, there's somebody. That's all right. I'm losing my words already, so it's very early in the morning for me here, so bear with me. I'm sure my colleague Yiyou will be much more fluent when he joins in because it's afternoon where you are. So as I'm saying, it's just really about, we want to hold on to the momentum that World Hepatitis Day provides. We know from the release of the new WHO reports that there's a lot to do, that whilst we have all the tools to reach elimination, there's a really big gap in action across the world. And currently, there are very few countries that are on track to reach elimination. So this session today is really about focusing on what's happening in the WHPRO region, to look at some of the best practice and to think about and maybe have some discussion around what do we need to do next in this region. So with that, I'm going to hand over to my colleague Yiyou from WHO for his short introduction.
Thank you so much, Rachel. My name is Kiyohiko Izumi. I am working for the WHO Western Pacific Regional Office, team lead for the HIV, viral hepatitis, and the STI. So distinguished speakers and the participants, good morning and good afternoon to everyone. So it is my great pleasure to welcome you to this important webinar hosted by the World Hepatitis Alliance and co-facilitated by the WHO Western Pacific Regional Office to commemorate the World Hepatitis Day. So today we come together to renew our commitment toward hepatitis elimination. The theme of this year's World Hepatitis Day, it's time for action. So, and this underscores the urgency of our mission with over 350 million people living with chronic hepatitis B and C worldwide, and millions more at risk. So the time to act is now. And the countries in the Western Pacific region here, very diverse, ranging from very small and remote islands in the Pacific to massive populations and the huge mega cities in other countries in our region. So more than 100 million, or 1/3 of the people in the world living with hepatitis B or C are in our region. So our region is a really high burden of the hepatitis. So more than 100 million, so despite of our progress that we made, so inequity and the lack of access to prevention, diagnosis, and treatments, especially for the vulnerable and unreached population, continue to be significant challenges. So we need to bring health services to people through the primary health care approach and commit to the universal health coverage and listen to the community voices. So our journey is marked by the significant milestones. So this year, WHO Western Pacific Regional Office established the Regional Validation Advisory Group on the elimination of the mother-to-child transmission of hepatitis B, HIV, and syphilis, and accelerated control of viral hepatitis and for the elimination. So this group will play a key role in validating elimination efforts in the member states in our region, and also advising on achieving our goals. So we are privileged to hear today from a range of the voices, from patient testimonies to updates on the regional progress and the country-specific experiences, and the launch of the WHO hepatitis dashboard. And these stories are inspiring us to move forward the elimination efforts. So thank you all for being here today, especially WHA as a webinar organizer, and MOH counterparts, partner, CSOs, and the participants in this webinar. I wish you a productive and inspiring session. Thank you so much.
Thank you.
Back to you, Rachel.
Thank you, and a fantastic introduction. Thank you very much. So it gives me great pleasure to move on to actually now we're going to have a patient testimony. We had hoped that Chang would be able to be with us, but unfortunately due to IT issues, he's unable. So Dee Lee, who I think probably needs very little introduction to anybody in this region, is going to present his patient testimony. And I think this is very much about how communities should be involved in taking action to improve access to diagnosis and treatment. You know, the role of community, and that's the central role and essential role in the community. We're going to reach elimination. And how do we ensure it actions effectively address the needs of the communities? So with that, I'm going to hand over to you, Dee.
Okay, because as we know that if you want to install something, especially in an APK here in China, things will be very, very tricky, because Zoom sometimes is on and sometimes off because of China Great Firewall. That's something we have to suck up, even though we have the heaviest burden of the the people living with hepatitis. But so I'm going to take the liberty to represent, not just represent, to speak for Cheng in terms of his testimony on how he feels about how he feels about the treatment and the access for diagnosis, and how we can eliminate the viral hepatitis B before 2030. So I'm gonna speak on behalf of Cheng's testimony, because I had him now on my hand. So a couple of things he feel he can do. The community organization can do to work together with all the stakeholders to achieve the goal. So my name is Cheng. The full name is Zhuo Cheng. So I started to, I had hepatitis B for the last 20 years. So I started to, have a slight cirrhosis, signs of cirrhosis, and I have to take the treatment from on and on. And very luckily that because of the treatment that is provided here in China, so it's easily for me to got a cure. Let's not say cure, it's treatable. Everyone knows that I'm treatable nowadays. If you are not in a severe situation, so my situation just got stabilized, but I'm still fear what I can do for my future life, because at the moment I'm leading an organization fighting the discrimination and stigma, predominantly in Guangdong province. So my job is to expose the human rights violation against the people living with hepatitis, but it's not easy for us to do the work. But in terms of what we can do to achieve the goal together, here's the three following things I can come up with as a community members, even though our work is very hard to run and on daily basis. So the first is to raise the awareness on hepatitis B, because it is something that the origin of all the disadvantage that, or maybe the stigma discrimination started it. So with stigma, with discrimination, there's no way for anyone can come out to get a regular tested or maybe the regular diagnosis. Sorry, the diagnosis and regular checkup to join the journey of the linkage to care, and not letting alone the treatment. Because when you dive into any sort of treatment, your identity is considered to be a patient, and it's very likely in many of the workplaces you will be sacked, and you will experience a huge amount of pressure inside of your family. So without tackling the stigma discrimination, there's no way for some sort of a smooth and tactical strategy to run down to achieve the goal together. That is, he said, so Cheng's, narrative is only in China. That's he can speak for himself, not to represent the whole, West Pacific region, but only in China. The second is to work with the medical organizations this is very interesting for him to say so, to establish a green path for the people living with hepatitis and the patient, to minimize the treatment process and waiting time. And also, especially to the people living with hepatitis B and C, the antiviral treatment is already very successful. One is totally, the cure, and another is treatable. What we fear, as Cheng said, what we fear about our life is cirrhosis and liver cancer, that a very diminishing period of time of our life. So, and also the counseling together with the green path for the people living with hepatitis is always a good thing for the community organization to work with the medical entities. So this will also help them to ease the anxiety, depression, and increase the confidence to fight against the viral hepatitis. Last but not least, it is the economic burden. We as community organizations needs to be working together with all the stakeholders for the society to to get more support financially especially for the people with the liver cancer and cirrhosis, because there's no way at the moment it's easy for anyone to go through this process predominantly in China. Last but not least, China experience is useful for some other countries, and also some other countries experience is useful in China. So having some sort of a collaboration between community organization globally would really help with the experience for each country to learn on. Yep. So this is his testimony. So last but not least, he said, "We need treat me instead of treat all. His final words to put on to end his testimony. Yeah, that's Cheng's testimony.
Thank you very much, Dee, and thank you very much to Cheng. And I'm so sorry that he wasn't able to be here with us today. And I think really important, perhaps we'll get an opportunity in some answering questions later. He raises stigma and discrimination, because if we don't address stigma and discrimination, we absolutely won't be reaching elimination. It is a core part in terms of people who are affected being able to access and feel comfortable accessing services. So it gives me great pleasure to move on now to the regional updates, and my colleague Yiyou, he's going to be moderating this session with me. So I'm just going to, first of all, there's a question already come in, and perhaps if you're okay waiting, Cecilia, we can come back in the Q&A just after these regional updates. Perfect. So I'm going to, for the World Hepatitis Alliance regional update, I'm actually going to pass you back over to Dee. So I think, Dee, if you'd like to introduce yourself, in terms of the World Hepatitis Alliance, Dee has been around for a very long time. I think that's the best way to say it. A member of the board when the Alliance was first set up. So it is a great pleasure to have him here as the regional board representative today. Back in this position after, I'm not even sure how many years, Dee. Perhaps you could give us an introduction and provide us with your regional updates from the WHA activities, past.
Okay. All right, I'm going to share my screen. Hope you guys can see. Oops. No. That's the last one. Yeah, this is the first one. So my name is Dee. Wow, when we talk about the Alliance, it really feels like ages ago. But each year, together with the team, predominantly in London, and also our board members together across different regions, can feel our work is, somehow measurable, and also being a role of catalytic to engage with different parties, different stakeholders, to achieve the elimination goal. There were so many setbacks, to be honest. Vaccination gone. There's no functional cure, and the stigma discrimination against people who inject drugs. Also, as a patient living with hepatitis C. Even though we always have a narrative nowadays, it is, we got everything ready, just let's do something. But as far as I'm concerned, as far as in my experience, that we are not getting everything ready in each regions. In terms of treatment, maybe yes, but to achieve the treatment, to really wanted to engage the different partners on the same table to do things together with the same mentality, we're not ready. So the Alliance in the last couple of years been doing a lot of work in West Pacific region to really wanted to create this the same one can say the same theme work for us to move on. We don't have to have a lot of shared value, but the consensus is always that there's a goal we need to achieve. We as community members, we as community organizations work together on behalf of our patients. So this regional updates is pretty much on for the last year. As first of all, we have the Asia workshop. It took place on in the mid-July. I was there. It's amazing. Even though that you can see the number is 46 attendees, 24 community-based organization, but don't forget this is coming all together from 15 locations to coming together to share our common practice, what we can do together to achieve the elimination of hepatitis B by 2030. So photo speaks more than words. These are the part of the participants in Hong Kong. And the workshop is a consensus. The final result of this workshop is a consensus statement, which addresses the adoptable and enforceable suggestion to drive policy and systematic change to reduce stigma, improve accessibility and delivery and health for hepatitis B. You can find the statement in our website. It's easy to read and it's not too bold. It's a very humble goal for us to work together. I myself have some, grunt about some of the wording are not too, aggressive, but that's the consensus that I'm going to say our committee members are really wanted to see. So I just go for it. No worries. It's calm. Let's go calm. So the workshop is an opportunity to share and learn from each other. That is some of the participants to really engage with us when you talk to us on how we can see the result. We can see some of the participants are here today. Chris, and 94% of the participants agreed the workshop enabled them to share the project and experience. I myself, of course, is a part of the 94%, but I myself when I took the survey, I said it really helped us to build the consensus and the also the common ground for us to work together. Before that, we just be doing our work on our own. There's no way for us to understand what's going on in Philippines, in Indonesia, and the other countries. But we find out some of the experience can be totally be utilized. Just what Cheng's testimony showed for the last point. Some of the experience can be totally utilized for each other. I'm sure that most of you joined the World Hepatitis Summit this year in Lisbon, April. It's organized by our alliance and also co-sponsored by WHO and supported by the Ministry of Health Portugal. Each summit has different themes, and I've been to all of them, and also the one in Geneva, because of the COVID control. I myself could not make myself there, but also I share some of the our findings there. So that's technically I joined every one of the World Hepatitis Summit. But one of the good things about the summit is that this year we no longer just a bunch of community members coming together to share about what good we have done. It's all about worries. We open our heart to deliver, to speak up for our anxiety, worries, and sometimes angers to the other participants, because we don't think it's very likely that we are not able to achieve the elimination goal 2030 as far as the process is concerned. So these are the numbers you can see: 700 delegates, and there are totally 40 sections. And the good thing about it is that 93% of delegates feel good about the summit. Is good for their organizations, and 69% of session features speakers and moderators who have lived experience of viral hepatitis. I believe 69% is among the highest in any sort of the hepatitis related summit or conference. And WPRO it's only 11% for our attendee, because the long distance between the Asia, the WPRO region to Portugal, and also the expense and everything else at the same time. So even though we are the region with the highest burden of viral hepatitis, but we only went for 11% of the attendees. It's only 11% of the attendees in terms of numbers. But never forget, for the next summit, 2026, it is announced we're going to hold the summit to 2026 in Thailand, which is amazing for us to join. And this is some of the engagement for the World Hepatitis Day 2024. As we know that the World Hepatitis Day was co-initiated by the WHA, the World Hepatitis Alliance, and the World Health Organization. And this is one of the few days that we use a very limited resources and also limited time to get it listed in the international platform. And so we launched a relay session with 45 members together, 70 time zone, across 70 time zone, with a short video of what hepatitis elimination means to them. And overall, there are 300 some million impressions and 35 tweets. The number is getting more and more each year. And I'm sure the awareness is increased over the world. But I would love to listen to your impression about what's going on with the World Hepatitis Day this year in your country. And this is the in our WPRO regions. We want to talk about the South Asia, in South Australia. So free liver fibro center and the local shop center. That is really something we share in the WPRO WhatsApp group. I myself, when I heard the news what's happening for the free liver fibro scans in the local shop, I'm really amazed and envious, because for me, I have to do the fibro scan once each year. It took me for at least $200 for me to get it through. And the people are lucky enough to have a free liver fibro scans in the local shopping center. And also for the hepatitis SA, this is a our community organization member. This is what he shared in our region. Some very vivid story here in his regions. So a joint letter, a Cancer Council with South Australia to member of the parliament, urging support for more funding for hepatitis B. Amazing. Quits for the prisoners. This is also one of the neglected group of the hard to reach people for us to move on. Because what I learned from the Viral Hepatitis Summit in Australia, I just came back from Darwin for that. I learned something very crucial to amend my knowledge. There is no hard to reach population. There is only hard to deliver service. If we can remember, there's nothing can stop us to do so. It's very lucky we for the hepatitis SA to launch such a quiz for the prisoners. So for me, I myself is totally. We're doing exactly the same thing in the past couple of years, to go to the labor-intensive workplace, to join, to work with our frontline workers, to tell them that if you experience some sort of stigma and discrimination and unnecessary job screening, tell us. We will help you to fight for the rights. We launch some sort of the activity during 2 days for the 3 days in a row, 26, 27, 28, and 29, together to our workers. What we just want to make sure that our work would not be disabled, because it doesn't mean we are not getting any cases. It doesn't mean that the stigma discrimination are not there anymore. And letting them know we are getting the cases on discrimination and stigma on daily basis. So just look ahead. This is the I'm urging the community members in the WPRO regions to join us for the very, very emerging issues for hepatitis D. I have a little knowledge about hepatitis D, but I'm not saying I became the expert, but my concern over the hepatitis D was increased probably like 10 times, 20 times more during the summit. There are so many, hidden cases with the co-infection between with co-infection of Hep D and Hep B at the same time. So I met the community member. Many of them said that, after treating for such a long time with Hep B, my data is still very high. My liver condition is still, deteriorating. But after a further diagnosis, actually it's a Hep D and Hep D co-infection. So I urge we together in our regions to join the survey together, to echo together in the alliance to tell us what do you think of the Hep D. My knowledge was terrible before the summit, but after the summit, when I talked to the community members living with hepatitis B and D at the same time, I feel ashamed and I feel like I need to do more. So the survey will launch in September 2024 for 6 weeks. The findings will be shared in early 2025. And also testing week. Some of the countries are still struggling with the free testing, but that's what we need to engage on our community members to say that the testing is what you need for the step one to get treatment. Without testing, there's no way for us to get more action support for our future work. So a global campaign highlighting the urgent challenge facing us, that is the need to drastically to increase the testing diagnosis of viral hepatitis if we are to reach the elimination target by 2030. So it's totally driven by the society. Let's join it. If you like the logo, please give a like in the alliance Twitter and social media account to say you like this some sort of the logo for the testing week, because I totally love it. So yeah, I just mentioned about Bangkok 2026. You have to come to Thailand for it. So with 70% of viral hepatitis related death occurring in Asia. So these really mean something, that we come together to address the issues for the very first time in Asia, for Asia, and of Asia. So yeah, I'm gonna end my simple, very, very, very simplified report on our WPRO region on behalf of the alliance. There are much more we have done for the region, but one of the things that we need your participation. We need you to be part of the journey to achieve the goal together in the big family. Okay, thank you.
Thank you so much, Mr. Dee Lee. That's a great presentation and a fantastic summary of the WHA activities. So we're gonna have a Q&A session after the next speakers. So it's my pleasure to introduce our next speaker, Dr. Amin Grabi. So Dr. Grabi is a dedicated viral hepatitis consultant, currently working with us in the WHO Western Pacific Regional Office. So he has made significant contributions to the hepatitis elimination in our region. Most recently, he has been leading the hepatitis national program review in Cambodia and the development of the national strategic plan for in Lao PDR. So please, Dr. Amin, hand over to you. I think it's a recorded presentation from him. Thank you so much.
Good morning and good afternoon to everyone. Thank you, and again, good morning and good afternoon to everyone. It's a pleasure to be here with you today and to present the new hepatitis section of WHO WPRO dashboard. First of all, as we are commemorating World Hepatitis Day, I want to say thank you to everyone who is involved in the hepatitis response, from awareness raising to service delivery. And thank you all for your continued effort to serve the most affected communities, not only by hepatitis, but also by other communicable and non-communicable diseases. If we take a quick look at the global data from the last global hepatitis report published earlier this year, we see that among a total of 304 million people that are living with chronic hepatitis B and C in 2022, 34% are in the Western Pacific region. This is about 104 million people. And also among a total of 1.3 million people who died of chronic hepatitis B and C in 2022, 42% were in the Western Pacific region. And in light of this high burden, our region has achieved significant progress by reaching 79% coverage for the hepatitis B birth dose vaccine in comparison with the global coverage of 45%. WHO and WPRO is working with all member states to address important gaps in testing and treatment coverage to ensure that we are on track towards the elimination target for hepatitis B and C that are set for 2030. And the launch of the hepatitis dashboard today comes at a crucial moment to improve our monitoring of the recent progress achieved across the Western Pacific region. Our objective today is to introduce the hepatitis dashboard, take you through its different sections so that you can have an idea about what to expect and show you how to access and check the main hepatitis indicator and data visualization that are showed in one single web page. This dashboard had been designed by the HIV, hepatitis, and STI team within WHO WPRO, and the hepatitis section is part of the broader integrated communicable disease dashboard, which provides the latest data and some digital tools to improve regional surveillance, monitoring, and analysis of the overall progress of the hepatitis response, both at regional and country levels. Additionally, it also offers a unified platform for monitoring disease burdens, not only for hepatitis, but also for tuberculosis, HIV, malaria, and other neglected tropical diseases. As you can see, the link and the QR code are displayed in this slide. Please scan the code if you want to check the dashboard. It can be displayed in your laptop or smartphone. Now I'm going to take you through the dashboard to give you an idea about what you can find in the hepatitis section. As you can see, the web page is loading. Now the hepatitis section of the dashboard is displayed. You can see on the left hand side, here you can choose which region or which country to display. Just one click give you access to all the 27 member states from the Western Pacific region. So you can, for example, choose Cambodia, and the dashboard will automatically display data from Cambodia. On the right hand side, you can choose to show hepatitis B data or hepatitis C data, and quickly the dashboard shows the relevant data for hepatitis C. You may have noticed that there are 4 different value boxes in different colors. These value boxes shows a key indicator for hepatitis. The blue one shows the prevalence for hepatitis B and C. The red one shows the number of deaths for both Hep B and Hep C. The green one is for the coverage of diagnosis, and the orange one is for the coverage of treatment. So you can get a kind of overview of the situation or key indicators by looking at these 4 value boxes. And if you can see in the bottom of each box, there is a small arrow and that take you to the source of the data. It's mentioned here, WHO, which is the Global Health Observatory. So you can access more details for the data if you want. Just click on that link and it will take you directly to the Global Health Observatory. Okay, so now let's move to the middle section of the dashboard. And here you can see we have 6 data visualizations. This shows hepatitis C graphs. We can switch to hepatitis B graphs. Quickly, we can have prevalence rate and also the number of cases per year if you prefer number than rate, and same apply for children. You can have the prevalence for children. Another graph is for incidence, and this graph can show also the incidence of chronic cases or acute cases based on mode of transmission, if it's vertical transmission of hepatitis B infection or horizontal transmission. You can change the time period if you prefer, and the next graph shows the number of deaths. The fourth one is for the coverage for the vaccine, hepatitis B vaccination, whether it is birth dose or third dose. Then two last graphs shows the diagnosis coverage and also the treatment coverage. And there is a small arrow here where you can download to save the graph as an image if you prefer. Switching back to hepatitis C, sorry if I keep switching between B and C, just to give you that the same thing apply to hepatitis C, and you can have 6 different type of indicators. Specifically for incidence, you can have incidence of hepatocellular carcinoma, for example, in a specific period of time. And also here you can find the link to the source of the data. This data is provided by CDA Foundation, and if you click the link on the bottom, it takes you to the data source, which is the dashboard and or the database provided by CDA Foundation, and we are very grateful to them for providing the data. Another feature of this dashboard is you can have the data shown in the maps of the Western Pacific region, and you can choose specific indicator. For example, here I will choose the hepatitis B birth dose vaccination coverage, and this will show differences in coverage between countries based on a scale that is shown on the left-hand side, and you can have a table where that shows the data when available. So you can have another form of visualization. Again, here you can choose any indicator that you're interested of, and these are like standard global indicators for the monitoring of the progress towards elimination targets. So I invite you to take a look and check different indicators. The last section of the dashboard is a table that actually shows the impact indicator and programmatic indicators. These are the targets for the elimination of hepatitis B and C as a public health problem. And when there is a small bar for each country, and you can see obviously there is two colors, green and yellow. The green means that the target is achieved, and the yellow, that means that the target is not achieved yet. And you can find the title of the impact indicator on the top row of the table, and the target just under it. And so you can have a kind of comparison between countries and see which countries are on track. And we are hoping that as we are progressing towards the 2030 target, this table will become more green, and more and member states and country will get closer to the elimination targets. So this is overall the dashboard for hepatitis B and C, and you can explore so many indicators in various forms of visualizations. And at this stage, we welcome your feedback, your comments, your suggestions, how we can improve this dashboard and make it more comprehensive, more accurate, and more user-friendly. Also, this is also an important point. So please, if you have any comments or suggestion, these are very, very welcome. So with that, I thank you very much, and back to the moderator. Thank you.
Great, thank you so much, Dr. Amin. This is a really fantastic initiative, and anyone can access to this dashboard and then explore the current epidemiological situation and the service coverage. So I hope Amin can put the link to the dashboard in the chat box, so easy to access to the chat the dashboard. So now we will move on to the short Q&A session. If anyone has question to the both speakers, Mr. Dee Lee and Dr. Amin, please raise your hands. And I saw some question on the chat box, but already answered by Amin and Dee Lee. Maybe while waiting for a question, I have one question to Mr. Dee Lee. So my question is what will be the most priority activity that the WHA in Western Pacific region in the next few years to accelerate hepatitis elimination goal? Maybe you can say a few words, your priority activity area in the next 5 years. Over to Mr. Dee Lee.
So so your question is trying to to roll out the discussion about what are the activities for the alliance to do in the WPRO regions to achieve the elimination goal. Is that the case?
Yes, exactly.
Okay. Maybe the participants, the attendees, you can raise your hand to give some suggestions over the panel to say what you think you can do more to work together. So before jumping into your questions, Izumi-san's questions, I'm gonna to reply Celia Lim just asked in the webinar chat. You asked what is a green path for treatment, because I can only I can't reply my answer to the attendee, so I'm going to answer verbally to Cecilia Lim. So your question is, what is a green path for treatment? As you know, not as you know, sorry. The reality is that people living with hepatitis don't have to wait for at least like 3 hours. And the number of the people living with hepatitis is between 70 million to 90 million. Trust me, the number changes from time to time according to the statistic in our country. So it's so if we have such a big population of living with hepatitis, we should give the green path, or maybe let's say speedy path for them and for us to see the hepatologist. And also we don't have to wait outside of the clinical area to be discriminated by the people. I had once my personal experience is that when I go to see my clinician, my friend as a hepatologist, outside of the the department, there are probably like 80 to 90, little less than 100 people, sitting and standing outside of the department. And these people, no one are there to get close to these, waiting people. That happened in 12 years ago. I'm sure, the mentality is still there, that people do believe that if I get close to the people living with hepatitis, I can easily get contacted by the virus or maybe infected by the virus. The same thing can apply to HIV/AIDS as well. But HIV/AIDS, in many of the clinicians, has a special department and special hospital for them, but not for hepatitis. So we have a group of people stranded together, totally treated like virus, but actually we are not virus. We are just only the people living with hepatitis. So we need the speed path for the I'm going to say for the people living with hepatitis in many of the big hospitals as well. To answer your question, Izumi-san, it's for us, nowadays, because in the last couple of years, the community members for the WPRO regions used to be very active. But when COVID hits, and also because of the some other political reasons or whatsoever, the community members are not very keen to work together and share together. So first of all, we need to break the silence of the partnership in the region of West Pacific regions. So so that's why we have a WhatsApp group. So that's why we have a lot of engagement and also share experience. And also the survey can bring us together to to raise awareness of the hepatitis D. So first of all, is to break the silence for the community, inside of communities. So the second thing, that would be the experience sharing. On the ground, there are so many types of, or maybe the types of experience that we can work together, we can totally utilize for each countries. But at the same time, that we have to come back to the reality that Asian countries, especially for the West Pacific regions, are doctor-led, narrative, and sometimes it's either doctor-led or maybe the public health sector-led. The voice of the communities are considered to be much lower against the other regions. So we need to bring the voice together to really to try to help people to understand we are doing terrific things on the grounds together with the other partners, not for the partners, with the partners on the ground. So that will be the second thing we want to do. So the third thing is the economic burden nowadays is still a very crucial thing for this region. So especially for the people who are developing the liver cirrhosis and the HCC as well. So we are trying to do launch some sort of a funding mechanism for the patient and community. Last but not least, it is my area as well, which is stigma discrimination. I was born to fight the stigma and discrimination, all my life, and I don't think I can, kill this stigma and discrimination in my life. So the alliance is now working a lot on tackling the issues of stigma discrimination to really engage with the community members and the media and many other people at the same time. So yeah, there will be 4 things we need to do to work together to eliminate viral hepatitis together.
Great. Thank you so much, Mr. Dee Lee. So you pointed out the very relevant points and four priorities: revitalizing community movements, sharing experience, funding mechanisms, tackling stigma discrimination. So we do hope that we're going to have more collaboration toward the next the Hepatitis Summit in Thailand 2026. So we're going to have more collaboration. So mindful of time, we're going to move on to the next session. Hand over to Rachel for the moderators. Over to you.
Thank you very much, Kia, and thank you very much to everybody. If you have questions that haven't been answered yet, please, I think that Dr. Marmi and Kia, if we can answer some of them in the chat box, we may have a chance at the end of the session, but we're running slightly late. So I'm delighted to be, my co-facilitator on this session is Dr. Amin. So great to see you with us. And we have some presentations, some updates from countries and CSOs across the region. So without further ado, I'm going to move us forward and introduce you to the perspective from the Yellow Warrior Society and Chris Monzo. Are you there, Chris?
Yeah, I'm here.
Fantastic. Oh, there you are. Sorry. Yes. Hi, Chris. Just hand over to you and your perspective from your organization.
Yeah, so I'm Chris Munoz. So thank you for inviting us here to discuss the impact of the new hepatitis B guidelines to people living with viral with the hepatitis B in the Philippines. Next slide, please. Next. Okay, so Yellow Wire Society Philippines, if there are still some people who are not aware, we started in August 16, 2009 and was registered in the SEC on 2010. We are a member of the World Hepatitis Alliance, an affiliate of SEVHAP, and a member of a Philippine Alliance of Patient Organization, which is also a member of the Union for International Cancer Control. And just recently, we are also a member of the International Liver Cancer Movement and a member of APAC Liver Disease Alliance. Next slide, please. So the Philippines is just one of the countries who are very privileged to have its own clinical practice guidelines. It also have its WHO pre-qualified test kits. The HBV DNA machine is also available because it is also being used for HIV and TB. But still, in 2019, the Department of Health just launched its pilot program in several cities in the Philippines. But despite of that, we encountered many challenges that patients were not getting treated or were not getting easy access to those who are implementing the program. So the good news is, at least now, because of the recommendation, it is much more simplified and low cost. So whether you go to a private facility or you go to the government facility, the treatment for the treatment is recommended to all adults and adolescents. And the significant of the simplified is that we don't have to use the HBV DNA. I mean, you can use it, but at least now it is not one of the criteria. It can be, you can use the APRI score, which is available. So for those who, in the Philippines, we usually call it, you have to get your SGOT and the platelet count. And of course, for those who can have access for the DNA, you can easily get treated if you're more than 2,000, rather compared before you have to get over 20,000. So, and the last two guidelines would expand more treatment to patients who can get liver cancer. Next slide, please. So the Philippines also has its, also privileged to have a registered medicines in the Philippine National Formulary, and Entecavir is available, tenofovir is available, TAF is also available. But in a government program, only TDF is given for free. And sometimes this gets patients confused because we have patients that have gone to the private doctors, and later when they learn that they need to take the oral medications for life, they shifted to the public. And usually, in most cases, those going to the private would be issued a TAF, right? So when they go to the public, they still have to go back to their doctor and ask that, am I allowed to shift to TDF, or I have to stay on TAF, which is very expensive in the Philippines, especially the Entecavir. Next slide, please. So again, even the mother-to-child transmission, which is one of the things that the Philippines is doing, at least now with the new guidelines, we expect more mothers to get treated. And of course, vaccination is always one of the things that we advocate for. Even in the Philippines, we have a law that, that babies should be vaccinated within 24 hours, and that you should complete the next three, what do you call this, the vaccination. So you have 4, the birth dose plus 3. But despite of this, the implementation is really not that high, not that good. It's almost at the 60 to 70% level. Next slide, please. So this is just a snapshot of where we can go. As if you're a private, if you want to go to access private, you go to the private hospital. If you're a patient, then you want to go to the government, then you can access to the primary, secondary, tertiary hospital, or the Department of Health hospital and social hygiene clinic. But this is not always the setup for every city. So you may see other cities that have no tertiary hospital or maybe they only have the primary and the Department of Health hospital, or you may see other provinces in other regions that has no DOH hospital. So it really depends and where you live. So it those living in the south of the Philippines would probably much have a harder time than those living in the national capital region, which is the main city. And every hospital or primary or tertiary hospital has its own capacity. So you may find other hospitals not having all the diagnostic tests that should be given to patients. Okay, so next slide, please. So for patient experience, we have some patients going through the facilities that can complete the journey within 8 to 12 days. So the first day they go to the doctor to consult. What I'm describing is a patient going through the public health facility or government facility. So they want to consult the doctor. Then the next day you have to go to you have to process your laboratory fees. And if you're being asked to pay, you may go to another unit to ask for it. It's like a social, like a social care. I don't know what they call it in English, but it provides payment. It's a payment mechanism so that the patient do not need to pay from out of his pocket. And the day 3 would be lab extraction. The day 4 would be lab result, and the day 5 would you have to consult the doctor, which means that maybe you can get rescheduled the next week. So that's why I check in on 8 to 12 days. So this patient journey, what we want to see is that we want patients not to go back and forth in the facility, and as much as possible, you don't have the patient go from day 1 to day 2, but the day 1 to day 2 actually takes, let's say, another 3 days, because you have to fall in line, you have to schedule your laboratory, and you have to get your results. So there may be facilities who are very strict in getting schedule. And of course, in the public health facility, you always have to fall in line. And we're not just talking about people living with viral hepatitis who are lining up. We're also talking about patients who have cancer, who have diabetes, who have other kinds of disease as well. So maybe the patient journey too, which is applicable also in other facilities, so that patient just gets screened, then gets diagnostic test within the day, and then the next day or after 2 to 3 days, the patient may get results and treatment starts if needed. So, I mean, for 2 days, maybe but it's like you're winning an Olympic gold, because example for me as a patient, when I go through the private, I go there at least, the very least is 3, because I have to go to the doctor the first day. You still have to wait for your turn. The second day, you have to get scheduled for ultrasound, and you have to do fasting and other results. So still have to wait for it, and the result will come out after 3 days. Then you have to go back to the doctor. So if you make it in 2 days, that's very, very good already. Next slide, please. Okay, so these are the challenges of the 2 implementers when I asked them, because they have been running their program for almost 4 years. So one is that they're struggling with the shortage of Hep B vaccine. I think there's a global shortage, or maybe there's a procurement shortage. And then human resource, because we know that when you use the UHC model, universal healthcare model, so you have to go to the primary care center, and you know that in the primary, there are lots of people who falls in line early in the morning, as early as 5 a.m. And sometimes those healthcare workers are really, I understand them. they work the whole day, and when you see more than 50 patients in the day, it really drains you a lot. And the next would be, they need the healthcare workers. Sometimes they change for some reason, so you need to retrain them. Then they say also that they need a reliable health information system. They need it to be more computerized, more digital, because when you just use the you use paper and pen to record everything, you would see that some information would be lost. And then of course, lastly, which is happens every year, is the delay of medication, the delivery of medication. But for patients, um, there are more challenges than implementers, because because of the devolved health system. So which means that each city has the right to choose whatever health programs that they want to give to their constituents. They may say that, okay, I'm an advocate of health, but I want to give priority to diabetes or mental health. But I think, they would probably say, or some would probably say that, oh, I would give more resources to building bridges, building schools, which is, we know that is also, we need those things, but they would not really advocate for health. The next would be the information asymmetry, wherein patients have lesser knowledge than the implementers, and sometimes, you need to explain to patients what they need to know. You just don't download the information to them, and for them not really understanding what they need to do. And then of course, lack of personal funds. Even though the program is free, they still have to travel, they still have to miss the work if they have work. And then number 4 would be self-stigma and discrimination, wherein sometimes people would refrain from going to facilities because they feel that they might get discriminated. And then of course, the long waiting lines. It's, you miss one day of work because you have to fall in line very, very early. And then sometimes when they have number 6 is the scheduling. Even though there's a scheduling, you get scheduled maybe weeks after or months after. And then the last would be, if you're getting treatment, you might not be able to get the 12 bottles in a year. You might, there will be a gap in between, or maybe in the last quarter of the year. Okay, next slide, please. Okay, so for me, there are only 2 solutions. I mean, these are very important solutions. Number 1 is increasing the finance. Money solves almost every problem of those implementers. They can address the needs of of the healthcare workers. They can finance the diagnostics, the screening, and medicines of the patients. And of course, number 2 is the community engagement, which is very, very important, because we want the patient to be, or the community to go to the facility when there's a program. But you need to engage them, to tell them that this is our system. What do you think about it? Would it be effective to have this kind of system, right? Because usually what we see is that those systems are only being downloaded to patients, and patients have to comply, right? But if implementers and community work together, there would be more flexibility on, let's say, on the time, how they address the patients, the gaps of the patients. There would be much more better understanding and a much more better uptake and continuum of care for the patients. So, in this drawing, this is what I envision, because I believe that there should be a shared responsibility for everyone. So what I can see is that the local government unit provides human resource and infrastructure, because that's where the patients go. The Philippine Health Insurance would support the cost of the diagnostics, so they don't have to go to the Malasakit Center, or have to go to the to other people to get money, just to get support for the cost of care. And then the Department of Health would provide medicines and that the families and community would provide the physical, emotional, and social support. So we want we want that kind of model wherein everybody supports the patient, and that the patient need not beg or need not go to every person to ask for support, to ask for what they need. So if we one more thing is that liver cancer in the Philippines is fourth, right? Is ranked in fourth. So if we want people to get, not to go to the cancer stage, the fibrosis, the cirrhosis stage, we must invest, right? We must invest in vaccines. We must invest in the treatment for Hep B to get it controlled so that people will not go to the liver cancer stage. Okay, next slide. Or I think that was the next. Okay, that's not my last slide. Thank you.
Thank you so much, Chris. I think incredibly, for the overview of the Hep B guidelines update in the Philippines, but, more importantly for me that, the message from the patients and really strong, clear messages in there around putting the patient at the center, getting the finance in. And reminding everybody that, there is a consequence here if action isn't taken with liver cancer. Great presentation. Thank you very much. I'm going to move us on now and introduce you to Hazel Hill from New Zealand, who's going to give us a brief overview. Hi, Hazel, of hepatitis B elimination in Yiyou. Over to you, Hazel.
Kia ora, thank you. I believe we're going to show a short clip now. It's the trailer for a film that I released on World Hepatitis Day. I'll show you the trailer and then I'll fill in a bit of the gaps after that.
Hepatitis is one of the most devastating diseases on earth.
I had hepatitis C nearly all my adult life.
She was pretty near death.
Most of liver disease is completely asymptomatic.
I hate it when I see there are better treatments available elsewhere and we don't have them.
What we've seen across the Pacific when there's a high incidence of hepatitis B infection.
Your risk of having hepatitis and of dying from hepatitis is more than 10 times that for people living in Western countries.
These are not trivial viruses.
People don't know much about hepatitis before the awareness.
In some cases, stigma and discrimination are worse diseases than disease itself.
If you have Hep B and you don't know what it means, then you might think that this is it.
At one point, I wanted to just end my life.
You've got to think about ways to ensure that there is equity in healthcare.
Countries look at their neighbours and decide what they should be doing in terms of health.
What's different about WHA is how you have handled the public health challenge.
I've always seen WHA as a world leader.
I just think it opens up a whole new opportunity for these people to have life and life in abundance.
The World Health Organization has set the target of 2030 to eliminate viral hepatitis from the world.
The ability to eliminate viral disease like that, it's a first step, but it shows there's a path. And then you start to think about other viral diseases. If we can get to that point, it's a pretty dramatic shift.
One loss of life, it's a big deal.
My friends laughed when I said,
oops, there we go. Okay, thanks for showing that, Raquel. So here we made that film really to tell the world and really a lot of things in a really simple terms, and to use WHA as an example for what else we could achieve in the Pacific. We're really poised and dying to get on with work in the Pacific. I've got ticking in my mind the number of people, how often they're dying, and with such a high burden in the Pacific, it's about every minute 45, I think, in the Pacific someone's dying. It's yeah, there's a lot to do. We want to move on to Tonga next. A couple of things I wanted to note about WHA's story. WHA has applied, we've applied for validation of elimination. We tested all the adult population, and what was really innovative about what WHA did is that they made a dual consent form when they did top-up vaccinations for COVID-19. So when they had people sitting there for 20 minutes, they were able to get their consent to have a finger prick test and do hepatitis screening in the 20-minute break of vaccinations. And I think that's a really good model, because we've got really well connected information now about populations for COVID vaccination, and we can tap into that. And also, you know, a lot of hepatitis screening is piggybacking on screening for other things in the region, like TB or syphilis, whatever wherever we can get in there and add on screening, we will. But, you know, my partners in the Pacific, they're just Alice Lee and my other partners, you know, we're poised and ready to go. We've got an amazing program. We've got real political buy-in. Dr. Pia Kala, who we met in Auckland a couple of weeks ago, and we were able to show him the full version of this film, a reduced version of this film, was very excited about it, because it's just the way it imparts the information and gets people forward. And yeah, we want it to empower. What it's done is fire up healthcare workers. They want to go and do a whole lot of testing now in Auckland and look for Pacific populations in Auckland. Problem with that is a lot of the Pacific populations in Auckland, they're not valued eligible for healthcare in New Zealand. So, you know, then it becomes a problem of finding people that we need to treat some other way. So what our group's doing at the moment, this is a really big project. I haven't got time to tell you all about it, but we're looking at setting up, well, we've actually found a partner. We're setting up a bonded warehouse in Auckland with the Ministry of Foreign Affairs and Trade's support, we hope. And that's to make like a collective buying opportunity for Pacific Islands to get cheap diagnostics and treatments, pull the buying, bring them into New Zealand, which we're not allowed to import some of those cheap medications into New Zealand because of the border laws, but we can import them into this, we can transship them through a bonded warehouse and keep them there, and then, you know, send 500 to Samoa and 50 to Fiji, and, you know, like spread the load so that countries can enjoy much cheaper diagnostics and treatment, and have like a core organization that's keeping an eye on things like stockouts and expiry dates and things like that, based in Auckland. So yeah, we're moving on that. That's another really big job. We wanted all of these things. We've got no funding. Got to say, I was so excited when I saw the Hepatitis Fund come out the other day, but it's not for the Pacific. So, you know, we can't do anything with that fund, which is a shame. And yeah, it comes down to it. We've got wonderful people. We've got real buy-in. We've got a real moment. I feel like we've got a real moment, a real spark. Our lovely guy that's in our film, Sione, he'd come back to Tonga with us and do an awareness campaign. And just a few minutes of Sione would be worth, you know, hundreds of hours of some other campaign, but, you know, we just can't fund any of it at the moment. So yeah, we'll keep trying, do what we can with what we've got. But I would love you, please, to watch and share the film, and I would love you to use it as a resource to gain allies or to inspire healthcare workers, because it seems to be doing that every time someone watches it. So yeah, I think that's about my 5 minutes.
Hazel, thank you so much. And well, truly inspirational and really powerful video. And please, just to remind everybody, if you please, you know, look at the whole version of the video. I haven't seen it yet. I can't wait to see it. And what an amazing initiative that you're talking about there. Because it's about countries helping other countries and working together, you know, and that is how it has to be if we're going to truly eliminate. We all need to step up and support each other. So that's fantastic. I'm just going to hand you over now to, and just to remind everybody, there will be an opportunity to ask questions at the end of this, at the end of the presentation. So the last one I'm going to introduce is the country experience, so the progress of the national hepatitis response in Cambodia. And I'm going to hand over to Dr. Yiyou.
Yes, thank you so much, Chair, and allow me to join this webinar to bring some progress of for the program for hepatitis program elimination in Cambodia right now. So let me share the screen. Can you stop the share the screen from the Philippines?
Please try again, Dr. Kyo.
Okay. Did you see my screen?
Yes, we can see. Thank you.
Okay. So I would like to say thank you again for this the meeting. I think very important for every country to learn to get some input from another countries, such as from the Philippines as well. I saw the issue is similar from the Asian countries. So I think for the one thing that I concern, the financing is very important. How we can accelerate the program to achieve the elimination goal by the 2030. So from the Cambodia, the National Hepatitis Elimination Program, we still have some. I want to show you some background information. So for the Cambodia, the data from the WHO report from the 2022, we have got the number of the hepatitis C, the chronic infection, from the estimated around like the ME, they show us around 1.2. So we estimate the number around 183,000. So this is the number that the Cambodia will have the hepatitis C infection. So the HCV incident maybe the 400, 600. So the number out there around 100 over. So sorry, 1,000 over. So the diagnostic coverage around 23%. So the treatment coverage is still left. So the 12%. So this I don't want to read from all the words, so you can see. So I just say the short word for the global hepatitis estimated success, the viral hepatitis B and the C, the other public health priority in Cambodia. So the summarized by the 2022, Cambodia had 23% of hepatitis C had been diagnostic, but the treatment coverage is less than the 12%. So if we look at the hepatitis B, we have only 5.3% that have been diagnostic, but the treatment, the coverage less than the 1%. So this will be a challenge with the Cambodia, but the data we got from the simplified model that implemented by the I said that's initiative of the for the hepatitis C elimination in Cambodia, but the project they gone so far from the 2021. So Cambodia have the national strategic plan. So for the hepatitis elimination program, we had the information regarding to the national strategic plan. So I don't want to read through the information in the presentation, so you can see. So we have the 6 strategy to eliminate the hepatitis in Cambodia. So the strategy 1, 2, 3, 4, 5, 6. So I don't want to detail because we had the comprehensive document like Anmi mentioned. So for the Cambodia, we have already document for the implementation of the viral hepatitis, but we start to develop to create the strategy plan from the 2020. So the period of the strategy plan we cover only 5 years. So they start from the 2020 to the 2040. So this year, this strategy almost we can say the expired. So we need to make the renew one, and we already have that with the consultant from the WHO that have the army and the WHO team from the headquarters and the regional also, and also we have the CDC Atlanta to join us to take a look, to review any area that had the missing, that had the gap inside the NSP that we had developed. So we will have the new one, but we're waiting the WHO, Dr. Ami, that will be the finish everything regarding to develop the new strategy from the for the Cambodia, from we used the period from the 25 to 2030. So this I just to show you the short for the program, the Chinese regarding the program, hepatitis program. So we start early from the 2019, but we still read more the column that you can see in this slide. So from this time we start up to the 2030, we just almost the yellow, the green. So we almost complete the document, and the area that we don't have from the 2019. So up to the 2030, we are already the green. So regarding for the domestic funding, we have the commitment from the government of the Cambodia. They allow us around 1 million from the 2023. But this budget we can use for the purchased commodities such as the rapid test B and C, and also for the country for the using expert to check check the virus before its treatment. And then yes, for the Cambodia also we still don't have the law and policy address the stigma and discrimination, but we still put inside the NSP. So maybe we will take a look at the point and which the new NSP that we will develop from 25 to 2030. And for the Cambodia also we can achieve the immunization program because not higher, but we can accept because that I saw from the national immunization program, maybe for hepatitis burden, maybe over 80%, but we will increase the year by year. So from the 2024, we also the commitment from the government still provide us 1 million the same, but so we has the budget for the maintenance the area, the scope of the implementation of hepatitis B and C elimination. We are still limited because from the NSP we costing the per year at least over the 5 million, because we want to expand from the 2020 to the 2030. So Cambodia had the operational district around the 103. So right now the Cambodia is still a small scope of work for the elimination the hepatitis. So we already have get the experience from the MSA that has the start using the simple model. So right now we try to decentralize the service up at the point of care and close to the community. That this point we can say the PAC. PAC the primary health care, because this place they can work, they can provide the service to the community close to the door of the patient. And the second point, we integrate. That means the Cambodia have mainly the program that using to reach the community as well, the HIV program, the MCA, NCD, etc. So we integrate align the target. We set the target from the Cambodia right now, depend on the commodities still limited and also the drug issue. So we decided to set the target. We select the people maybe from the 40 years old aligned to the NCD, because the NCD they had some fund to support from the World Bank and another donor. So they had the activity, so we joined them, and then at that time we can detect and treat. But the issues for Cambodia, the commodity not much, as I mentioned earlier. So the third point, we testing that means that we can allow the health facility. That means that we start from the health center. So the health center at the health facility, the capacity still limit just a nurse and the midwife, etc. So we can allow them to initiate DDA. They mean provide for the hepatitis C for the treatment as well. So the third point, we do the simplifying for the for the reaching the diagnostic and treatment, because from the start from the experience from the I said we start to using to appointment with the patient and the doctor or the nurse, something like that, maybe the almost more than the 10 time to meet. Example from the I said 16 time to finish the treatment. But now we switch from the 16 time to the 5 time only to the 5th. So this just show you the flow of the service. So when the patient come to the health facility, we start to education, and we start to, if the patient accept for the health education regarding to the hepatitis B and C, we start to do the rapid test, and if we found the positive, we take the blood and send to the referral to check the viral load to confirm the virus, and before we start with treatment. So if the viral load confirm had the positive, we start to we explain to health facility at the grassroots level at the health center to see to check with the patient that the positive for the hepatitis C, they have the combined that we co-infection with another disease like the HIV, like the non-communicable disease, the diabetes or hypertension, etc. If they don't have anything, we just positive from the hepatitis C, we let the health facility, the nurse or the midwife, initiate treat the patients using the DDA. So this is the flow chart of the for the Cambodia. We cut the short time, only the 4 or 5 times only. We will complete the treatment of the patient for infected hepatitis C. So regarding the hepatitis B, we separated two, but from the start of the screening, we used the both at the other level, health center and referral also, and national hospital also. So, but we separate two parts. If the patient come to the health center, that means health center, that means at the primary health care, if we found the positive of the rapid test HBA antigen positive, we need to refer the patient to the referral hospital to check any eligible for the treatment before we provide the TDA. So we just separate like that because from the WHO guideline and also the Cambodia, the guideline for the treatment of hepatitis B, we still set the criteria to check the transaminase ALT and the viral load also over from the Cambodia side, we set over the 2,000, something like that. So we need to check at the referral hospital, because at the referral hospital they had the lab capacity to check the afrim or the alat transaminase, etc. So before they provide the TDA. So if the patient not fit to the criteria for the eligible of the treatment hepatitis B infection, we need to defer. But we set some criteria, but I cannot say the more detail. But we are know from the WHO guideline. So right now, if regarding to the national hepatitis guideline for the treatment, we need to revise also, because Cambodia start from develop this from the 2020 up to the 24 over 5 years. So maybe we need to review and revise and to make the comprehensive and the easy, like the from the Philippines. So maybe we need to adapt the WHO, but depend on the content, depend on the source that we have, some like the commodity, etc. So if we look at the map of the Cambodia, I just say called the circle, but we have only 6 provinces. Cambodia, they are the 25, but the 6 provinces we not cover full the provincial, but only the 3 provinces that we can cover full. Example, the Bandabon, we cover the full operational district, because this is led by the MSS from the 2021. So another the province not the full like the Siem Reap. There are the 4 operational districts, but right now we cover only 2. But if we have the fund more from the 20 up to now or the 2025, we will scaling up to the for the whole province, like the Siem Reap, there are 4. Now we remain 2. Example for the Kampong Cham, there are 10. Now we got we start to implement it of the hepatitis B and C only 2, so remain 8. So we will continue to scaling up for our activity, and also the PUSAT. So just among the 6 provinces, we cover only 15 operational district, and if we can say the Red Cross also only the 18. Yep.
Sorry for interrupting. We are under time pressure, and I would be grateful if you can wrap up in 30 seconds, please. Sorry.
Okay. So I pick up. So the result from this table, maybe it is still a little bit because the data they get from the MSA only. So, but up to now that we have the more data from this one. So the B also this a smaller number, but okay, we will update, and we can input some achievement from the hepatitis B and C. So this the SWOT. So then the time limit, I don't want to read all of this, as you can see, and opportunity only that I want to say we have the commitment, decision maker, policy, and from the all level to support the program, and also the government still continue to provide 1 million per year. So I think that's about the challenge we have in the same another the country. Yeah, for the funding support, and also the capacity lack of the staff also. From the Cambodia, there are only 2 or 3 people responsible for the hepatitis program. Okay. So the next step, I don't want to read also, so you can read yourself. Okay, so I want to finish. This is a picture, just the last one. So this is a picture from the program review, from the workshop, dissemination, etc. Okay, over. Thank you so much.
Thank you so much, Dr. Samley, and apology because we are over the time. So apology to all the participants, and please, I think we try to wrap up and finish the remaining presentation by the next speaker in the next 10 minutes. So it's excellent to hear about the activities that are being implemented in Cambodia, and it's my pleasure now to introduce Alethea Tan, who is the Hepatitis Program Manager, new initiative manager at Clinton Health Access Initiative, Cambodia. So as it had been highlighted, access is a main challenge. So please, Alethea, if you can give us your perspective in the next 5 minutes. Thank you.
Great. I'm going to keep it very short, given we're over time, but I just want to, again, echo some of Dr. Samley's points. We work very closely together. And before that, I do want to say, I know Dr. Samley spent quite a bit of time talking through challenges, but CHI has been supporting the CDC since 2020. And honestly, the amount that they have achieved with such a small team has been incredible to watch. And we're just very grateful to have been partners to them on this journey. And just to recap a little bit, because I think maybe Dr. Samley didn't quite cover how much they've achieved since then. In 2020, they were really picking up and trying to figure out a way to scale up the viral hepatitis program. And since then, as he mentioned, they've been able to advocate for domestic funding 2 years in a row, and hopefully that will scale in future because the program has gotten off the ground. Late last year, actually, Dr. Samley and the CDC, tiny but mighty CDC team, led the eventual rollout of viral hepatitis services in 15 operational districts at primary healthcare level, which is unprecedented. It's a real step in the right direction to decentralize critical services. And now I think we're really seeing that go in the right direction with the new HPV guidelines. So just to say, I think Cambodia has done a lot in the past 4 years, and CHI is very grateful to have witnessed it. In terms of challenges, I did want to raise a few, which Dr. Samley has touched upon. One is financing. And I know he's mentioned hepatitis, as we all know, is often overlooked. It's hard to get funding, and I do urge all of us to work together more and think through how we can tap onto other pots of funding, which we've tried to do. For example, of course, Global Fund would be one of them with their shifting focus on triple elimination. But to be very honest, it's still not enough. I think sometimes it comes as HIV, syphilis, and then Hep B. So definitely that's something we're seeing as a challenge, although hopefully that is changing. And the second point is also diagnostics. I think we've done amazing work as a global community to bring down prices of RDTs. Something still needs to be done, I think, about viral load confirmatory testing. I think that's still been a challenge for us, both in terms of patients accessing it, because it means they probably have to come back more than one time, and also because honestly the cost is sometimes too high, both for the health system to bear and also for clients seeking it in private facilities. And the last point I did want to mention, which is both a challenge and also a success in my view of Cambodia's CDC and actually Dr. Samley, is that my impression, and I've only been working with him for less than a year, is that he has been unfailing about his commitment to actually making sure that every hepatitis, a person living with hepatitis, gets treated. And this is something that we don't often see in the global health language of cost effectiveness, or maybe just focusing on where it's easy or where we can achieve elimination. But every conversation I have with Dr. Samley, he's always like, well, if someone gets tested and someone is living with hepatitis, we must treat them and we must make sure that we are making their lives better. And the reason I bring that up is obviously with chronic HBV, that's going to be a lifelong condition. And often it is hard for us to find and mobilize funding, whether domestic or global, for chronic conditions. And I did just want to raise that because it is something we're seeing both in Cambodia and across the region, and I'm sure globally as well. But also, I just want to say, like, Cambodia, like CDC has never given up, and I think Dr. Samley is committed to treating every person who he finds, but that is definitely a large gap that we're hoping to fill. Over.
Thank you so much. Thank you for sticking to the time and highlighting the cooperation or the collaboration between CHAI and the national program. You said working together. This is exactly what we need to do, and access is an important issue. So working together on this specific issue is really important. So thank you for sharing this perspective. So it's my pleasure now to introduce the next speaker. Ms. Oriel Fernandes is the Senior Director at the Global Viral Hepatitis Program at CHAI. So Oriel, the floor is yours. Thank you.
Thanks so much, Emil, and thanks so much to the WHA and WHO WPRO team for organizing this webinar. I would like to share some perspectives on sort of broader access challenges and opportunities to hepatitis drugs and diagnostics in the region, building on some of the perspectives that Alethea and Dr. Samley and other speakers have talked about from their country context. Now, I think a few minutes is not enough time for us to dive into all of the details for hepatitis drugs and diagnostics access. So what I thought I would do is just start off by just sharing, where different participants on this call can find information on drug and diagnostics access. And just to say, CHAI routinely publishes reports on the hepatitis market, which are all available online and through our website. And we do this for three main reasons. One is to provide market transparency and enable stakeholders, both governments and partners, to make informed decisions about procurement and product procurement choices. Secondly, to showcase the key drivers and barriers to scale access to affordable diagnostics and treatment, and then to highlight where we see emerging market trends and innovations that can have significant opportunities to improve care for patients. So just to flag in the slide, we've hyperlinked the different reports and also a link to one of our recent webinars where we dive into all of the details on drug and diagnostics access, both globally and specifically for the regions that you can, hopefully tune into after this webinar. So if I could have the next slide, please. I just wanted to sort of take an example of one commodity, so treatment for both hepatitis C and hepatitis B, to share a couple of reflections on where we see some of the challenges for access specifically to drugs for hepatitis. On the slide, you'll see pricing for 12 weeks of soft DAC treatment on the left-hand side graphic, and on the right-hand side graphic, you'll see pricing for years treatment of tenofovir across a range of countries in the region. And just to call out, in each of these graphs, the orange horizontal bar indicates to you where current global access pricing stands for these commodities. So this means that most countries in the LMIC regions who are part of the licensing agreements for soft DAC, and again, tenofovir doesn't have a licensing agreement, so all countries should be able to actually access these commodities at the price indicated by the orange bar. So a couple of reflections on HCV treatment. Over the years, hepatitis C treatment has fallen significantly since 2014 with the introduction of more effective treatment and the expansion of a generic landscape for DAAs. And we now have a global access and referencing price that enables HCV DAAs to be available at $60 for 12 weeks treatment course, and I'll talk about that in a little bit. I think overall, while we've seen a lot of progress in the region toward hepatitis C elimination, as you've just heard from all of the amazing work countries like Cambodia are doing, it's striking to me that the pricing remains really varied across the countries, and the effect of the globally decreasing DAA prices have not translated evenly across countries in the region. And a lot of this pricing differential is really driven by a couple of key factors. First of all, fragmented demand. So in countries where you don't have a centralized program where the government or other partners helping pool procurement, the market is subject to very fragmented procurement. A second reason might be suboptimal procurement practices. And a third reason for some countries is just distributor markups and where generic DAAs are registered. So just a challenge to highlight here, I think over the last few years, we've seen that procurement volume for DAAs has remained very low, with the procurement just being driven by a few countries. And this is a major risk for the market because we're now starting to hear suppliers are concerned about the market. Over the last few years, we've seen a couple of suppliers exit the process for WHO PQ, and some suppliers are asking us whether there's still a market for hepatitis C. So I just wanted to call that out as a big risk. Moving out to the right-hand side of the slide, we see a similar story for tenofovir. Countries are accessing tenofovir at very different prices. Some countries at really moderate to high prices, despite the high burden in the region, and despite tenofovir being a mainstay drug for HIV and being very cost-effective for HIV programs. And the few countries that are procuring at lower prices, in some cases, are using, various donor fund support, like the Global Fund. And so some of this pricing is currently limited to small groups of the most vulnerable patients. And other patients have to pay out of pocket for these high costs. So I think the bottom line from this slide is we still have a long way to go on achieving market access for hepatitis treatment. And, if you refer back to the reports for drugs and diagnostics that suppliers produced, and as Alethea just talked about, actually, the storyline is the same for diagnostics as well. We see very, very pricing for diagnostic commodities and similar challenges there. Could I have the next slide? So I think the main question is, what initiatives and what opportunities are available to countries in the region to get better access to pricing? And I just want to talk about a few opportunities. I think, firstly, on treatment, recognizing the price variability between countries, trying the Hepatitis Fund signed agreements with generic suppliers to facilitate an access price for hepatitis B and C treatment. And on the left-hand side of the slide, you'll see details of this agreement. At what price are these products available, who's providing this product, the quality of the product, and who has access to the agreements. And I think the main thing to call out here is any stakeholder, government, partner who's procuring on behalf of the public sector has access to purchasing these products at these prices, which I think should really be an incentive now for governments and donors to be coming in and funding hepatitis programs. And then on the right-hand side, you'll see steps for how countries can get access to these products. And I won't talk about all of these steps given we're limited for time, but I think the most important thing we need to start doing is ensuring that everybody's aware that these pricing agreements exist and can start using them. And I think the last thing I'll just call out here is the risk over here. You know, I think I talked about low procurement volumes in the last slide that I spoke through, but just to really highlight this again, despite having these pricing agreements for both hepatitis B and C treatment in place over the last year, procurement volumes have not increased and are still quite low. And this is likely due to a lack of funding for hepatitis programs. But as I said, this presents a really big risk right now, as recently suppliers have indicated concern that the lower pricing points for these commodities are just becoming unsustainable for them with low procurement volumes. And I think the key risk here is that these pricing agreements are at risk of going away if we don't use them. And we've already had one generic supplier who's pulled out of this agreement because of low procurement volumes, and we're doing everything we can to keep the second supplier in the agreement. So I think that the thing to just take away here is I really want to encourage all Ministry of Health representatives, all donor representatives, all partners to really think about how we can plan to build procurement for hepatitis products and ensure that we don't let this opportunity go away. And if you have any questions specifically about these pricing agreements, please reach out to me or anybody on our TRI team or the Hepatitis Fund or the WHO, who's always been very involved and supportive of market access. Could I have the next slide, please? Just to call out quickly, as we do for treatment, we also have a global access price available for viral load testing. All the details are on the slide, but I just wanted to call out just on the bottom of my slide to the right-hand side, you can see the key global access pricing points for viral load assays. So if your country is not accessing viral load at a pricing point that's at this price or close to this price, I think we need to start asking questions why. And again, please reach out to partners who are facilitating this webinar to help at least explore why the country is not accessing at these prices. Could I have my final slide, please? So I think just to end, I want to cover some overall reflections and a way forward for how countries in the region can get better access to hepatitis commodities. And just say up front that the global access pricing deals, while they pave a way for rapid scale-up for hepatitis programs, this is just only one piece of the pie, and we need efforts from the whole global community really to reach hepatitis elimination goals. And while there's no one-size-fits-all approach for each country, I'd say there are a few things that all countries need to start doing for us to ensure a more stable market for hepatitis and better access to hepatitis products. So firstly, we need to start allocating financing for programs. Procurement of commodities will not happen if you don't have financing strategies and funding is not allocated for procurement. I think secondly, as I said before, we need to start using the global access pricing deals. It makes me honestly feel very sad and frustrated that there are global access pricing deals for hepatitis treatment and viral load testing, and countries as partners are not using these deals. I think thirdly, there are a bunch of different strategies that countries can employ or partners can employ to improve procurement practices, recognizing that the global access price is the price you pay to the supplier, but by the time the commodity leaves the supplier's warehouse and reaches the country, multiple costs get added onto that product, whether it's distributor costs, whether it's import taxes, custom duties. And so we have to do everything we can to ensure that those additional costs are kept low, and ultimately the savings that we're getting from these access deals are passed on to the patients. And so, in the slide, we called out several things that countries can do to, keep these distributor markups or additional markups low. First of all, you can think about establishing longer-term contracts with certain suppliers. You can implement centralized procurement systems. This pooling procurement centrally can really help with achieving best prices for procurement. You can leverage pool procurement mechanisms through donors like the Global Fund or UNDP and other donors that support this. And countries can also consider local manufacturing. There are certain countries in the region that are locally manufacturing some of their drugs and accessing their drugs at lower prices. I think the last 3 points are very self-explanatory, so I won't cover them in the interest of time, but I think maybe the last point is just to say it's been really wonderful to commemorate World Hepatitis Day with all of you and speak at various webinars about market access over the last 2 weeks, and just want to encourage us to think of every day as World Hepatitis Day, because there's a lot of work for us to be doing. So with that, I'll just pause there and pass it over to Rachel and Amin. Thank you so much.
Thank you, Oriel. Thank you so much. So it's important to say that global access prices do exist now. The challenge is that countries use these prices, and WHA is going really important work in this area. So I would like to hand over to Rachel for the closing remark, and if there is any question, we will address them in the chat, please. Thank you.
Thank you, Amin, and thank you to all the speakers today. We've been incredible presentations. It's been a privilege to be a part of the meeting and for me to learn so much. Thank you to all of you for attending. And I'm really conscious we have run over by it's not just a little bit, by 30 minutes. So thank you for sticking with us and being a part of this meeting. I guess what I take away from this, and I think we heard the same messages over and over again, there's integration, decentralization. We need government commitments, and we need government commitments with action plans. And as Oriel's just saying, with those action finance plans and commitment of resource and financing, we heard loud and clear messages from patients, put the patient at the center, and that's part of the decentralization and integration. The WHO dashboard, fantastic. It was incredible to see that, and as patient organizations, that's an incredible lobbying tool for us, because you can take that to your governments and you can say, look at what you're doing, or look at what you're not doing, and look at what other countries are doing. We have to address stigma and discrimination. There has been so much today, and I'm so sorry that we haven't had an opportunity to actually do more Q&A, but I think we can take learning from that and make sure that we, shift it around a bit more, so there's a bit more time for other people to ask questions. And I guess the thing that I leave with is, for me, is that I'm going to go back and I'm going to watch that video that Hazel started showing us. I think that's an incredibly powerful video. Go back and see more. I love the idea of, different, working together across borders, across countries, because if we are going to reach elimination, we really do only have a couple more years to get back on track, or we're not going to do it. We need to be doing it together. So thank you all so much. Thank you to my co-hosts. Thank you again to the speakers, and for you all being here and for the incredible work that you do. So Kiko, Aman, Dr. Aman, thank you so much too for joining us on this presentation, on this webinar. I wish you all a good evening, afternoon, day, wherever you are. And thank you again for joining us. Bye-bye.
Thank you. Thank you.
Thanks, everyone. Bye.
Thank you. Sorry it was run over so much.
Bye.
Bye-bye.
Bye.